It really, and I may have referenced this earlier, but it is somewhat difficult to really gauge and estimate or objectively measure a patient's intravascular volume status. And so, as a clinician at the bedside, if you are tasked with the decision to give a patient IV fluids or not, you have to think of what objective measures you have to help guide that decision, because there are harms in giving fluids to a patient that may already be fluid resuscitated. And there may be harms in giving a patient some other therapies instead of fluids if they are hypovolemic. So I think the terms optimization, personalization is really trying to use objective data, and some of those I think we have even yet to discover, is how to better assess volume status. I think right now, if you look at various different disease states or even just general practice, if a patient becomes hypotensive or if they present to a medical facility with a perceived potential diagnosis of, let's say, sepsis, for example, there is no personalization related to their fluid administration on the front end. We have a set idea of what volume we should give. Um, if a patient comes in with a hyperglycemic crisis, such as diabetic ketoacidosis, you're going to give the patient 2 liters of resuscitative fluid. If a patient comes in with sepsis, you are going to give them 30 milliliters per kilogram. And that is at face value, not individualized. That is a blanket statement. We are not even sure yet which body weight to use for sepsis, for example, ideal body weight, adjusted body weight, or total body weight.